So thing is, we'll divide this into maybe 4 weeks of Clubfoot. The first week we'll try to cover the nomenclature, because this is something which is very often confused, and we keep asking whether is it one type of Clubfoot or the other. One of the other things we'll be trying to cover today is how to evaluate the child once the child comes in for the first time to the clinic, and how to make sure that this is indeed an idiopathic clubfoot and not any other type of clubfoot. So the other weeks is going to cover the radiology. It's going to cover the grading system, that is both the Pirani and the DiMeglio, that is week 2. The week 3, we will be trying to cover in detail about the Ponseti method of casting. And by week 4, we will be doing the operative methods of plastering, of CTEV correction. Okay, so without further ado, let's start. So what is clubfoot? Any foot that looks like a club, a golf club, is basically clubfoot. Okay, so it's a very sort of a generic term. Okay, so it's a generic term given to any deformity where the extremity looks like a club. Now, this could be a club hand, or it could be a club foot. Now, one thing we need to make sure is that every CTEV is part of a club foot, but every club foot is not CTEV. These are two different things. And we need to make sure that we are on the same page with this. Okay, that every club foot is not CTEV. However, every CTEV is a club foot. Okay. Apart from a club foot, there are also other conditions like the club hand, such as a radial club hand, etc. So all these preaxial deficiencies of the upper limb all come into the club hand spectrum of deformities. Now coming to CTEV, which is congenital talipes equinovarus, which means it's a congenital condition affecting the talus and the foot, where the talus and the foot go into equinus and varus. Now it represents a congenital dysplasia of all the musculoskeletal tissues distal to the knee. They can be musculotendinous, ligamentous, osteoarticular, and neurovascular. So all of them, it is not just the bones and joints which have turned inwards, but also the ligaments, the joints, as well as the neurovascular structures are at fault here. Now, these dysplastic features lead to the deformity seen in clubfoot. And what are the deformities that we see in clubfoot? We can call them by the mnemonic CAVE, that is cavus, adductus, varus, and equinus. So this is something we need to keep asking ourselves repeatedly. What are the deformities? How do we correct it? The mnemonic remains the same, that is cavus, adductus, varus, and equinus. Now cavus and adductus are going to be in the midfoot and the forefoot, whereas varus and equinus are going to be in the hindfoot. Coming to the epidemiology, it's quite a common condition. The epidemiology is about 1.2 per 1,000 live births, and it is more in developing countries. Every 1 in 4 children having a CTEV is born in India. That's about 25% of the cases happen in India. The male to female ratio is about 2:1. So it's more common in boys compared to girls. 40% of the cases are bilateral. And if the parents have clubfoot, then there is a 3 to 4% chance of transmission if one parent is affected. And if both the parents are affected, then about 15% chance of transmission is there. Okay, so there also is a hereditary transmission, but it is extremely rare. Okay, so in the general population, we have about 0.1% chance. So this is equal to a 0.1% risk of having clubfoot in the general population. However, if there is hereditary transmission, that the parents are affected, then there is about a 3 to 4% chance of transmission. And if both the parents are affected, then 15% chance of infection. If you want to continue forward in the same stead, then there is a risk of 30% transmission in monozygotic twins. Okay, but these are all just numbers. So what it's more important is that the risk is increasing. It increases more with the chances are more if the parents are also affected. Now coming to theories of clubfoot, there are many theories about how club feet happen. It goes without saying that at present we are at best in the unknown cause. However, there could be an arrest in the embryonic development which leads to clubfoot, because in the fetus, the feet are generally pointed inwards. So there is an arrest in embryonic development somewhere which may have led to clubfoot. Then you have the primary germplasm defect, which is basically a germplasm defect in the thallus. And here it was mentioned that a problem, that is a germplasm defect in the thallus, led to all the deformities seen in clubfoot. Then there were neuromyogenic imbalances where a particular type of the muscles all had white type of fibers. That means they were all fibrotic, leading to a muscular imbalance that's on the posteromedial side. Okay. Similarly, we had the congenital fiber type disproportion, where type 2 fibers were more commonly seen than the type 1 fibers. However, you might not have to remember any of these. What you have to remember is the myofibroblastic retractile response, because this was the theory given by Ponseti. Now, this theory, which is also known as a retracting fibrosis theory, mentions that clubfoot occurs due to fibrosis of the muscles, fibrosis of the capsules, ligaments, and tendons on the posteromedial aspect of the foot. Okay, it is due to a myofibrosis secondary to increased fibrous tissue in the posteromedial aspect of the foot. Ponseti also found that collagen was present in collagen in all the ligamento-tendinous structures was loosely crimped and could be stretched. However, the Achilles tendon had tight crimps of collagen and was resistant to stretching. So what do we mean by crimps? Crimps are basically turns in the collagen fibers. Now, these crimps are easily openable. So they open up, they stretch out and become a longer structure in all the ligaments and tendons of the foot except the tendoachilles. Okay, so this is what Ponseti has told us, that the crimps develop on stretching in the collagen fibers of all the ligamento-tendinous structures except the tendoachilles. So these collagen fibrils were amenable to stretch, and crimps would reform in about 5 days. So if that's how the crimps were on day 1, we stretch it. Post stretching, the crimps increase in size. However, the crimps reform between all of these structures. On day 5, we stretch it again. And on stretching it again, the crimps open up further. Okay, so they reform and so crimps are basically these connections between adjacent collagen, the hexagonal fiber, the cross-linked fibers. Now these will reappear 5 days after stretch. And then they will be amenable to re-stretching. So every 5 days, 5 to 7 days, they will reappear. And that's why every consecutive plaster in a Clubfoot is put after 5 to 7 days.